Hello and welcome to your prescription for medication education. My name is Yenmi and I have a simple goal to bring you quality information regarding medications and health related topics. So let me just go ahead and begin with today's video. I'll start off the videos with 3 questions and at the end of the video I'll go ahead and provide the answers. Question number 1. A 29-year-old pregnant patient at 31 weeks gestation presents to clinic with a blood pressure of 152/94. Repeat blood pressure 4 hours later is 150/92. She had a normal blood pressure reading before pregnancy and during early prenatal visits. Urine protein testing is negative. Platelets, serum creatinine, and liver enzymes are normal. She denies headache, vision changes, right upper quadrant pain, and shortness of breath. What is the most appropriate classification? Is it A, chronic hypertension, B, gestational hypertension, C, preeclampsia without severe features, or D, preeclampsia with severe features? Question number 2. A 36-year-old pregnant patient with chronic hypertension is currently 24 weeks pregnant. Her blood pressure is 146/92 at 2 separate visits. She is not currently taking any antihypertensive medication because her previous provider only treated if blood pressure reached severe range. She has no proteinuria, normal platelets, normal creatinine, and no symptoms. Based on current recommendations, what is the best next step? Is it A, no treatment unless blood pressure reaches greater than 160/110? Start or intensify antihypertensive therapy with a goal of blood pressure of less than 140/90. C, start magnesium sulfate for seizure prophylaxis. Or D, deliver immediately. Well, I don't know about that last choice, but. And the last question. A 64-year-old non-pregnant patient admitted for a foot infection has repeated blood pressure readings around 188/112. He denies chest pain, shortness of breath, neurologic symptoms, vision changes, or severe headache. Serum creatinine is unchanged from baseline, troponin is negative, and there are no signs of acute target organ damage. What is the most appropriate blood pressure management approach? Is it A, give IV hydralazine immediately to rapidly lower blood pressure? B, start an nicardipine infusion with a goal of a systolic blood pressure of less than 140 within 1 hour? C, evaluate for contributing factors and adjust oral antihypertensive therapy without aggressive acute blood pressure lowering. Or D, lower blood pressure by 25% within the first hour using IV antihypertensives. Let's review what the recommendations are regarding hypertension in pregnancy. One of the leading causes of pregnancy-related mortality are hypertensive disorders in pregnancy. Hypertension in pregnancy has its own classification, so let's take a moment to review them. In pregnancy, hypertension is defined as a systolic blood pressure of 140 or higher, or diastolic blood pressure of 90 or higher on 2 occasions at least 4 hours apart. Severe range hypertension is defined as a sustained systolic blood pressure of 160 or higher, or a diastolic blood pressure of 110 or higher, with verification within 15 minutes to allow for early treatment. Further classification takes into account gestational age and whether there is maternal end organ involvement or proteinuria. Chronic hypertension is defined as a diagnosis made prior to pregnancy or when a diagnosis is made prior to 20 weeks of gestation. Gestational hypertension is defined as new onset hypertension occurring on or after 20 weeks of gestation in a normal tensive patient. Preeclampsia is defined as gestational hypertension with either proteinuria or maternal end organ dysfunction. Examples include neurologic findings, pulmonary edema, renal or hepatic dysfunction. And lastly, preeclampsia superimposed on chronic hypertension is defined as preeclampsia in women previously diagnosed with chronic hypertension. For patients with hypertension and plan on becoming pregnant or who are currently pregnant, then the options to treat hypertension are labetalol and extended-release nifedipine. These options help minimize fetal risk. Either choice is fine as there is a lack of data supporting the use of one agent over the other, but nifedipine extended release does improve adherence with its once daily dosing. For patients at high risk of developing preeclampsia, low-dose aspirin after 12 weeks of gestation has been shown to significantly reduce the risk for preeclampsia compared to placebo. It also shows a significant reduction in preterm birth, small for gestational age, and perinatal mortality in those patients at increased risk for preeclampsia without a significant increase in postpartum hemorrhage. Although I mentioned this in my previous videos, I want to re-emphasize the importance of avoiding certain antihypertensive classes during pregnancy. These include ACE inhibitors, ARBs, renin inhibitors, and spironolactone. Spironolactone is generally avoided because of its potential anti-androgenic effects on fetal development. One medication I did not mention in my previous videos is atenolol. Atenolol crosses the placenta and has been associated with reduced fetal growth and small for gestational age infants, so it should generally be avoided during pregnancy. Up to 30% of women with gestational hypertension will go on to develop preeclampsia. In patients with chronic hypertension, approximately 20 to 50% may develop superimposed preeclampsia. Current ACOG guidelines recommend that patients with gestational hypertension who present with severe range blood pressures be managed using the same approach as patients with preeclampsia with severe features. In patients with preeclampsia, the development of severe features, or HELP syndrome, is associated with increased maternal and fetal neonatal risk. HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelet count, is considered one of the more severe forms of preeclampsia. Eclampsia is defined as new onset seizures that cannot be explained by another cause. Both preeclampsia and eclampsia can occur before, during, or after delivery. Magnesium sulfate is used for seizure prevention and treatment in patients with preeclampsia with severe features or eclampsia. The 2025 ACC/AHA Hypertension Guidelines give a Class 1 recommendation that pregnant individuals with chronic hypertension should receive antihypertensive therapy with a target goal of less than 140/90, which is a change from older ACOG guidelines which had a less stricter goal. This is due to the CHAP trial, which stands for chronic hypertension during pregnancy, which showed that treating to less than 140/90 reduced the composite preeclampsia with severe features, medically indicated preterm birth, placental abruption, and fetal neonatal death without evidence of fetal harm. For patients with severe range hypertension, we should lower blood pressure to less than 160/110 within 30 to 60 minutes. This applies to chronic hypertension, gestational hypertension, preeclampsia, and eclampsia. Options for urgent blood pressure control include IV labetalol with an onset of action in 1 to 2 minutes, immediate release oral nifedipine with an onset of action in 5 to 10 minutes, and IV hydralazine with an onset of action of 10 to 20 minutes. Hydralazine remains an accepted option, although maternal hypotension and abnormal fetal heart rate changes may be more common compared to them with the other agents. The last topic I want to cover to wrap up the topic of hypertension is hypertensive emergencies and severe hypertension in patients who are not pregnant and are not presenting with strokes. Hypertensive emergencies are defined as blood pressures greater than 180/120 and have evidence of acute target organ damage. These patients require immediate reduction of blood pressure to limit further organ damage. Unfortunately, there are no randomized controlled trial evidence that antihypertensive drugs reduce morbidity or mortality in patients presenting with a hypertensive emergency. There is also no high-quality randomized controlled trial evidence distinguishing which first-line antihypertensive drug class provides the greatest benefit versus least harm in these scenarios. For hypertensive emergencies with certain compelling conditions, treatment goals are aggressive. In most of these compelling conditions, the goal is to lower systolic blood pressure to less than 140 within the first hour. In acute aortic dissection, the goal is even lower, with systolic blood pressure reduced to less than 120 as rapidly and safely as possible. There are no randomized controlled trials evidence for the treatment of other forms of hypertensive emergencies without compelling indications. For these cases, blood pressure reduction should be more conservative. It's recommended that blood pressure should be reduced by no more than 25% in the first hour, followed by a gradual reduction over 24 to 48 hours to avoid hypoperfusion of organs. Severe hypertension, previously referred to as hypertensive urgency, refers to blood pressures greater than 180/120 without evidence of acute target organ damage. These patients should not have blood pressure lowered aggressively, and the guidelines state that these patients should not be administered antihypertensive medications parenterally. This is because hospitalized patients with asymptomatic severe hypertension experience spontaneous falls in blood pressure without any hypertensive medications, at a rate of 40 to 50% per the guidelines. Observational studies have shown initiation or intermittent use of additional IV or oral antihypertensive medications in patients hospitalized for non-cardiac conditions are associated with increased risk in in-hospital mortality, acute kidney injury, and prolonged hospital stay. Instead, these patients should be treated in an outpatient setting with intensification to the current regimen and evaluation for medication non-adherence or contributing factors. And the answers to the questions at the beginning of the video are 1 Bravo, 2 Bravo, and 3 Charlie. And that was your dose for medication education. I do hope you enjoyed today's video and learned something from it. If you did, please consider subscribing and feel free to leave me a comment below. It would mean a great deal to me. Thank you. Have a great day.